Hello KJR readers, I'm Sang from Hallym University, Dongtan Sacred Heart Hospital, South Korea. It is a great pleasure and honor to have the opportunity to present my paper in KJR. Today, I'm going to talk about prognostic prediction based on DCE and DSH-MR imaging parameters from non-enhancing T2-High-SI intensity lesions in patients with glioblastoma. Peritumoral non-enhancing T2-High intensity lesions of GBM consist of a mixture of reactive edema and infiltrative tumor, and it is difficult to differentiate them on conventional morphological image. Peritumoral non-enhancing infiltrated tumor, which shows high signal intensity on T2 weighted image, commonly remains after standard treatment of GBM, and most recurrence develops around the original treatment field. Tumor microvascular leakiness could be a non-invasive prognostic predictor because immaturity of microvascular structure, microvascular leakage, and active neoangiogenesis is a characteristic of GBM. So, this study aimed to compare the prognostic value of parameters from DCMRI and DSH-MRI within non-enhancing T2 high signal intensity lesions of GBM. From April 2010 through May 2017, a total of 269 patients who were newly confirmed with GBMs were consecutively enrolled in this study. Inclusion criteria was newly diagnosed GBM and received preoperative DCE, DSH-MRI, and standard treatment. Exclusion criteria was absence or inadequate image of one of DCE or DSH-MRI and other treatment regimen except standard treatment. Final study population of this study was 76 patients, and all patients had undergone follow-up brain MR imaging when they visited the outpatient clinic. At each time point, the assessment of treatment response and categorization of these patients into progression and non-progression groups has been performed on the basis of the RANO criteria. Consequently, based on the 6 months after surgery, 15 patients were categorized into the early progression EP group, and 61 patients were classified into the non-early progression NEP group. All MR images were acquired using 3 Tesla imaging scanner with a 32-channel head coil. The MRI protocol is shown in this slide. For DC MRI, 3D gradient echo T1 weighted image was acquired after the intravenous injection of GBCA. 40 images were obtained at same intervals at the TR for each section. DSH MRI was performed using a single-shot gradient echo API sequence after IV GBCA. 60 images were obtained at same intervals to the TR for each section. This figure illustrates the schematic diagram of the imaging processing. 2 reviewers manually determined artery input function, AIF, by located RI at the Willis circle or distal ICA that produced the best fitting AIF curve and concentration time curve. Afterward, the K-trans, VE, VP map of DC-MRI and normalized CBV and CBV map of DSH-MRI were computed and co-registered with the contrast-enhanced T1 weighted image and FLAIR images. The reviewers meticulously defined volume of interest VOI for FLAIR consisted of the contrast-enhancing portion, necrotic cystic regions, and non-enhancing T2 high signal intensity lesions in each slice. Yellow color VOI. The VOI for contrast-enhanced T1 weighted image covering the contrast-enhancing areas and necrotic cystic regions was also drawn manually using the same described above method. Green color VOI. After subtraction of green color VOI from yellow color VOI, final VOI of non-enhancing T2 high signal intensity lesions in only peritumoral area is defined. Finally, parametric values are quantitatively calculated from the final VOI. Cumulative histograms of the K-trans, VE, and NCBV was used to find the optimal percentile point with highest AUC. Afterward, survival analysis was performed using Cox regression and Kaplan-Meier survival analysis. Let me show you the results. This table shows clinical characteristics of the study population, clinical information of the patients, including the age, sex, radiation dose, Kanofsky performance status score, IDH mutation status, and MGMT promoter methylation status were not significantly different between the EP and NEP groups. The mean K-trans and median VE were significantly higher in the EP group than the NEP group. In contrast, the mean or median values of VP and NCBV were not significantly different between the EP and NEP groups. The 95th percentile value PV of K-trans derived from the subsequent cumulative histogram analysis was also significantly higher in the EP group than the NEP group. As a result of analyzing the cumulative histogram of K-trans, the 95th PV K-trans revealed the highest AUC in early progression prediction, with AUC of 0.704, p-value was 0.005. In contrast, there was no statistically significant percentile values for identification of early progression in cumulative histogram of VE, VP of DCE-MRI, and NCBV of DSH-MRI. ROC curve analysis was also performed to access the prognostic performance of mean K-trans and median VE, which were statistically significant different between the two groups. The AUC values of mean K-trans and median VE reached statistical significance in prediction of early progression. These box-Wilks plots show the statistically significant different values of permeability parameters between the NEP and EP groups. 95th PV K-trans, mean K-trans, and median VE of EP group show significantly higher compared with NEP group. In univariate Cox regression analysis, the hazard ratio of mean K-trans was the highest among the DCE-MRI parameters, followed by 95th PV K-trans for the prediction of early progression. However, median VE and NCBV were not statistically significant in the prediction of early progression. We included age, sex, 95th PV K-trans, and mean K-trans in the multivariate Cox hazard regression analysis for early progression prediction. Among those variables, only the 95th PV K-trans was significant as independent predictors of early progression. The 95th PV K-trans was also a significant prognostic factor for the prediction of early progression on Kaplan-Meier survival analysis. The high 95th PV K-trans group showed significantly shorter PFS than the low 95th PV K-trans patient group. The median PFS of high and low 95th PV K-trans group were 281 days and 347 days, respectively. I'll show you representative cases. Upper figure is representative cases of early stage progression. PFS was only about 4 months. Lower figure is a representative case of non-progression. PFS was 37 months. The irregular enhancing mass with internal necrosis and non-enhancing T2-High-SI density lesions at the left temporal lobe is illustrated on baseline structural image of FLAIR, contrast-enhanced T1 weighted image, and the perfusion and permeability parametric map of K-trans, VE, and CBV, respectively. As shown in the upper figure, after the standard treatment, heterogeneous enhancing mass is shown on contrast-enhancing T1 weighted image of follow-up MRI along the surgical margin in 4 months after surgery, confirmed as early stage progression. On the contrary, in the lower figure, there was no definite measurable enhancing portion along the surgical margin on follow-up MRI in 32 months after surgery, diagnosed as non-progression. The red bar and black line in the cumulative histogram of perfusion or permeability parameters shows the distribution of K-trans VE and CBV in the non-enhancing peritumoral T2-High signal intensity regions. The cumulative histogram of K-trans and VE of early progression reveals less steep inclination and wider transition area when compared to the corresponding cumulative histogram in Roh-Eul figure of non-early progression, and this means that early progression group has more higher parametric value than the non-early progression group. Limitations. Because of the manual determination of the VOI, there may be the limitations of subjectivity and low reproducibility. However, using the aforementioned subtraction method between the two VOI masks, we define the margins of the true non-enhancing T2-High signal intensity regions with confidence. The small sample size of the EP group, 15 patients, may not provide sufficient power to reveal a statistically significant difference in the diagnostic accuracies. Further clinical researches might be needed to verify our study results. In conclusion, DCMR permeability parameters of non-enhancing T2-High signal intensity lesions in patients with GBM were superior candidates as prognostic imaging biomarkers compared to DSCC MR perfusion parameters. Especially, the 95th PVK trans was the most important parameter in the prediction of early progression of GBM. Thank you for your attention.